as doctors ourselves. So I would like to propose that digital eye strain actually should have a re-nomenclature, and it should become a digital eye syndrome or spectrum. Because it involves not just visual and ocular symptoms but extraocular and other symptoms as well. So why is it that a digital device and not a book can cause strain? Because the simple answer or the simplest answer is pixels. Because the book doesn't have pixels, it has a print. Pixels are clearer in the center than in the periphery, and they lead to more of an eye strain. This is a recent conference. Let's just look at the pixels, one of the shared WhatsApp photos. So we don't even realize it, and this causes convergence fatigue. These are all the symptoms that we usually have due to digital eye strain, and we all know that. So I would again, like I said earlier, divide these symptoms into optical or visual, which may be blurring of vision, double vision, focus abnormalities, and hence accommodation related. They could be ocular surface related, and of course habitually there can be the position, the lighting, and all the other aspects, the timing, and all the non-ocular symptoms, including pain in the neck, back, shoulders, posture, even sleep issues. All these come under the ambit of the third one. Of course, this also means that the digital eye strain patient can come not just to the ocular surface specialist or the cornea specialist, who will now need to look under the ocular surface, but also to the optometrist or refractionist or the squint specialist even sometimes to the neurologist because of headaches. So the asthenopic symptoms or the strain symptoms are usually due to the convergence, accommodation, and pupillary miosis, and they include the diminished power of accommodation, distancing of the near point of convergence, and phorias. In children, they may lead more to esotropias, whereas in older people to exophorias, convergence insufficiency, etc. Of course, these are more associated with uncorrected refractive errors, and especially hyperopia and astigmatism. These are some other symptoms. We know, as we've seen in the first slide, that brightness matters, contrast matters, and screen glare also matters. There's something called screen refresh rate. If it's less, it causes flickering of the screen. There's an optimum flicker rate or the fusion frequency, which needs to be 30 to 50 hertz. Otherwise, the picture or the video comes as flickering. That itself is a very risky or dangerous thing, especially it can be epileptogenic. If the flicker is too much, sometimes it can induce autism in children. So again, we just saw also that what we call as this polarity, the dark or the negative polarity also matters. And also, of course, when we look at a textbook, we look downward. When we look at a screen, we look horizontally or upwards. Looking downwards has many advantages because it helps in the blink. It reduces the amplitude needed to blink. It completes the blink. So not just a blink happening, but a complete blink happening is important. And that reduces dryness. Also, it reduces the evaporation looking downwards, because the dryness also reduces because we're looking downwards, less of an exposed area. So, of course, there have been innovations in screen, including high-resolution screens, inbuilt anti-reflective coatings, matte finish glasses, image smoothing. Just look at the difference between an ambient light, which is dark or dim, versus brighter light, which is more easy on the eyes to see. Also, look at the interplay between ambient light and the screen light. So here, in both the images, there's a disparity. There's too much of dark ambient and too bright a screen, or vice versa. So that itself causes eye strain. Glare, on the other hand, we should not have the light from in front of us or from above us, but from the side or obliquely backwards. So this is how glare looks, and there are anti-glare coatings nowadays. Ocular surface related symptoms, of course, we know are dryness, burning, grittiness, heaviness. Blink has a lot to do with this, complete blinks, and again frequency of blinks. These are very important. So we need to blink 10 to 12 times a minute, we know that, but we do not when we are looking carefully or very attentively at screens. So this is something we need to practice and get ourselves to do more. So there's a desiccation of the tear film, and hence the dryness and the dry symptoms. So of course, There's air conditioning, which is again associated with these computers, because computers and digital screens are more placed in air-conditioned environments. There can be something as simple as a Xerox machine. The chemicals through that also reduce blink rate, as I said, incomplete blinking, increase exposure due to horizontal gaze. This is how the replenishing of the tear film usually occurs. Of course, if people already have dry eye, they'll get aggravated. We need to specially ask children or people who are using screens about use of antidepressants, because these again aggravate dry eye. So faulty illumination we've already seen, and treatment of course we know has to be multifactorial, multidirectional, and we don't need to yet throw away our computers of course, but we need to first change our habits, the ergonomical approach, we need to attack the surface, and of course we need to have any optical treatment. This is how the posture should be. There's a 90-90-90 rule. We do not need to speak too much away from the computer. There's an ideal distance around 30 inches from the computer. There's a rule for that as well. This is the rule for posture by the American Optometry Association. The 20-20-20 rule asks us for every 20 minutes to look at least 20 feet away for 20 seconds. And about the lighting, we've already seen it's better diffuse than focal. And also the ambient light needs to be matched with the screen light. As we've seen, the lighting, the position of the window and the lighting we've already seen. There's something new called the full spectrum light, which is nowadays available, the newest kid on the block. And these are supposed to be more easy because they simulate sunlight. Blue light, yes, this is the most talked about blue light, and we have blue light filters. What happens is the pineal gland and the melatonin secretion is directly dependent on this, because a blue light around 460 nanometers is supposed to be a potent suppressor of melatonin production, and hence the sleep issues through all these LED, LCD screens. So what about the distance? So we need to have the distance of the laptop around 2 feet, and this is the 1-2-10 rule, I would say. And angles of course matter, we have to look downwards, and so this strain reduces. This is mobiles at 1 foot, laptop screens at 2, and bigger screens at 10 feet. Every 5 seconds we need to blink, every 20 minutes we need to look away for 20 seconds, every 1 hour we have to get up from our place and move, because this itself is very important. Lubricating drops, of course, for the actual dry eye issues can be used, but humidifiers for the AC, some other treatments. Of course, there's some fancy things called wink glasses. Every time there's a shootout kind of this thing here, which shoots out and it reminds you to blink. And then, of course, we need to correct the uncorrected refractive errors. We can use blue blocking lenses. But more effective would be to stop using the screen 1 hour before bedtime, or to switch to the warm mode, because that helps in the sleep issues. Computer display settings we've already seen. In short, let us summarize, and these are the other factors which may play a role: the diet, the exercise, lifestyles, adequate sleep, stress control, and workplace settings. Effects on kids are not just limited to the eyes. There are language delays, impediments in life skills, obesity, diabetes. As I said, epilepsy, even autism can be aggravated. There are psychosocial risks as well. We need them to have more of green time, not just due to the screen effects, but also due to the epidemic of myopia. So our role finally is not just to ourselves and our community, our children, but also to the other doctors. Corporate awareness program, we can have patient awareness material like the one we created here from our department. And finally, I'd like to wrap up by saying that when I take a lecture on digital screen, digital eye strain for my students, they are the ones who tell me, ma'am, you are the one using the PowerPoint, and then you're telling us not to depend on this. But that doesn't mean that we have to go backward or we have to regress back to the era of the blackboard. But no, we don't have to do that. We don't have to go forward and go into robotics either. But we need to think outside the box and create a balance. So thank you.
One small question is, if we compare mobile, laptop and desktop, which one you think will put more strain?
So these are all the LCD, LED and these all have pixels. So if they are not held at the right distance, the right angle and so they will all cause eye strain.
That we know, but if we compare out of these three, because person has to use one gadget.
So the thing is that we have
If
tried
you have
to
done
find
any study on it,
that projected devices may have less of a strain because they are not illuminating by themselves. Those which are self-illuminating may have more of a strain, like these LED, LCD screens. But there's no.
in my practice, I am advising patient you should watch TV instead of seeing movie.
Because of the distance.
Because of
Yes.
distance.
And also, but the thing is that again we need to have the distance of at least 10 feet. We should try and not look up because then the evaporation
Yeah,
is
that
much
is
more.
eye level or
It's
below
more
eye level.
difficult on TV because we sit on a sofa to watch the TV. So again, this is a very big thing. We had a 1-minute video made specially for all these rules encapsulated just from the patient's language kind of.
One thing also I want to add, I have studied somewhere, you should not keep your mobile near you in the night.
That's true to the radiation.
It is
and
carcinogenic.
Yes. So there is so much more to in our hospital. 4 departments are really worried about the screen. The ophthalmologist, the pediatrician, because the children are language delays and a lot of other problems, autism. The psychiatrist, they've already classified digital use as an addiction, with all definitions of addiction already into it. And recently the EMR people, the physical medicine and rehab people, said there's something, the posture's gone really bad and the head is going back into ape-like, so they're really worried about it.
I can add on to it. If you find the orthopedician, people have trigger thumb. Because
And
the way people are typing, the younger generation,
yeah.
this is, earlier you would see the joint damage here. Now, people are coming with the joint damage here at a much younger age because of the speed with which they type.
Also, amongst the
Cervical
doctors,
is
the
also-
radiologists were the first to be affected because they had screen use for 6 to 8 hours as a part of their work itself.
Yes. Thank you so much.
Thank you.
Thank you. Myopia management, integrating research and clinical practice. Dr. Ghulam Ali Kamdar.
Good morning, everyone. In this part of the session, I will discuss the current practice pattern of the myopia management and the advanced practice pattern, advanced management of the myopia. There is a notable prevalence of the myopia in the world. Increased screen time, Madam discussed in her presentation, and reduced outdoor activities are significant contributor to the rising rate of the myopia, and half of the world population will be affected by the myopia by 2050. And glaucoma and myopic maculopathy. That's why we manage myopia in early stage. And we should manage myopia to decrease the economic impact of the myopia on the country, on the family, and as individual also. These are some instruments which we use for the early detection of the myopia, to know the progression of the myopia, and to the early detection of the risk element of the myopia. These are the highlighted one are the current practice pattern in our country. First is the lifestyle changes, increasing outdoor activities and the reducing prolonged near work can help manage myopia progression. And low dose atropine is commonly used in our country. And nowadays myopia management or myopia control glasses is also available, and they are used by the clinician frequently. Low dose atropine is proven to slow myopia progression by up to 60%, making a critical option for the management. And the emerging treatment like 7-methylxanthine show potential in inhibiting scleral thinning, offering alternative to the atropine, but still it is not available in India. Both orthokeratology and the multifocal lenses contribute to decelerating the elongation of the eyeball, and which is a primary factor in the progression of the myopia. These are three principles: peripheral defocus, high order aberration, retinal image contrast, on which myopia control glasses are working. The combination therapy commonly used in our country is the atropine with the myopic glasses, which show the promise of slowing eye growth. Other option is the low dose atropine with the ortho-K lenses, and ortho-K paired with the red light therapy also, but it is not common in our country. Public awareness is the key to the myopia management. Building public awareness is crucial in combating myopia and promoting healthier vision habits. Spending more time outdoor is associated with the lower incidence of the myopia, suggesting environmental factors play a crucial role. Font size and contrast. A small font size, closer reading distance, increase chances of the myopia, and the low contrast demand more effort, potentially worsening the myopia. Vision therapy is also helpful to prevent myopia. This is a new technological advancement in myopia care. Multimodal ensemble method combining color photo, fundus photo, and the OCT to predict myopia onset and to predict the myopia progression also. Early identification of the high-risk individual using genetics markers enable preventive strategy during the childhood. Potential use of the gene editing technology to address genetic mutation linked to the myopia. This technique, corridor cross-linking technique, aims to support patients with a progressive myopia who do not respond to the traditional treatment. These are some devices to monitor the behavior of the child, reading habit of the children and the adults also. This wrist wearable device monitor the light exposure to the children outdoor activity, and glasses clip which will be held here in the glasses, which is notice the reading habit of the patient, how close to the monitor, what is the angle of the patient head to the monitor. This is the key takeaway in the bridging gaps between the scientific finding and their application in managing myopia, focusing on the proactive measure to identify myopia at its onset, tailoring intervention to individual patient need for the better vision outcome, continually advancing practice and policies to support myopia management. Thank you very much.
Thank you, Dr. Gulam, for nice presentation. Our next speaker is Dr. Sumita Mohapatra. Topic is why do patients present late in glaucoma and how to avoid glaucoma blindness. उनकी जगह प्रेजेंट कर रही है क्या? She is not there. नहीं है, कहाँ है? अच्छा, ये
Very good morning to one and all present here, and I thank the scientific committee for giving me this opportunity. So my topic today is why do patients present late in glaucoma and how to avoid the glaucoma blindness in our country. I don't have any financial disclosure to make. So when we see the magnitude of the problem, we can understand how big that issue is about glaucoma blindness. Among Indians, glaucoma prevalence is between 2.7 and 4.3 in adults aged 40 years and above, and it's causing blindness in 1.2 million people and accounts for 5.5% of the total blindness. That is a huge burden of glaucoma, and almost 10 to 33% of the people with glaucoma had advanced disease and were visually impaired at the first diagnosis. So we all know that the late the patient present with glaucoma, the more chances of blindness for his or her life. So why do patients present late in glaucoma? We have to analyze it. There can be delayed diagnosis, there can be inadequate or improper treatment, and there can be non-compliance to the treatment. So in case of delayed diagnosis, why the diagnosis is delayed? Because glaucoma is an asymptomatic disease, and all these things can occur which will cause the delayed diagnosis. There is lack of effective screening strategy because glaucoma screening in the population community-based screening is not feasible, and opportunistic screening is the only method when we can catch some glaucoma patients, and we have to screen the first degree relative of glaucoma patient, and we can take the help of optometrists and train them properly so that they can detect glaucoma at an early stage, and AI-based algorithms and tele-ophthalmologists are coming nowadays, and they will help definitely us to screen the glaucoma patients. So another cause of delayed diagnosis is inadequate glaucoma awareness. Glaucoma awareness is not very much in our general population, so it should be an ongoing process, not as a special event like a glaucoma prevention week or awareness week like that. It should be a continuous process. We can take the help of information brochures, QR coded linked resources, mass media channels, and running messages on the screens when the patient is waiting for his next visit time. So those should be utilized to create the awareness. And another cause of delay is at the patient's level, because it is asymptomatic, and our population is not very keen of going for regular visit, so it gets unnoticed most of the time. And usually at the age of 40, they go to the presbyopic correction and they get a glass and come back. But many of the optical shops do not have any optometrist assistance, so it gets missed. The vision is corrected to 6/6 N6, but it is missed because of the lack of comprehensive ophthalmic examination. And availability and affordability are definitely issues which is a concern for the delayed diagnosis presentation. And sometimes the people think that it is a deterioration of the vision is a normal aging process. They think that we have got cataract, and once it gets matured, we will operate. But when they think it is matured and the vision is totally lost, it is due to glaucoma, and nothing can be done about that. So another thing is that misdiagnosis. Even if the patient visits an ophthalmologist or optometrist, it can be very well missed, because we rely on a high amount on the IOP measurement. IOP 21 more is glaucoma, less is not glaucoma, but that is not the case, and it has got its own limitation. And threshold for the IOP induced damage is not same for all the patients. Sometimes we can see that the patient has visited an optometrist, but his optic disc has been never looked at. So that is a condition, and even if it is looked at, so many things are missed if we do not look at the subtle points. That is underestimating the vertical curve disc ratio, missing the RNFL layer defect, and missing the disc hemorrhage and neuroretinal rim loss. So in a GONE project, it has been found that almost 1/5 of the examinations, they miss in the trainees and the general ophthalmologists, they miss the early glaucomatous changes. So these are the things we have to carefully look at. And the misdiagnosis, and another very much blunder is missing an angle closure component, because angle closure is very much predominant in our part of the country, our part of the world, like the Asian countries. And one should have a gonioscopy if we suspect. Otherwise, the angle closure glaucoma will be treated as an open angle glaucoma, whereas only a simple PI will help. But the patient lands up in absolute glaucoma because the angle closure has been misdiagnosed as glaucoma or other refractive error or some other causes. So missing an angle closure component should not be there in our condition. So these are the things which can cause glaucoma, like pseudoexpulsion, which is very common, traumatic glaucoma, there is steroid-induced glaucoma. All these things should be looked at. And if the patient IOP is not controlled with this routine test, and even after the patients have reached the target pressure, then we have to think about the other things also. And there is inadequate or improper treatment. Why this occurs? Because sometimes the severity of the damage at baseline is underestimated. If we target pressure is dependent on the baseline damage, if we underestimate the severity, then what happens? It set is a higher target pressure is set, and that leads to less aggressive treatment and ultimately disease progression. So missing IOP is another thing which usually occurs if we only record the pressure once in the day, and though it is difficult, then at least it should be done in cases where we expect that the pressure should be lower, but it is not getting sufficiently lowered. So non-compliance to treatment is also very much in case, because glaucoma is an asymptomatic case, and when we start treatment for glaucoma, the only thing patient experiences is the side effect of the drug, but not the benefit, because we have to convince him that there is no chance of any benefit, but only we have to halt the disease process at that stage which he has presented to us. That should be imprinted in the patient mind. Imagine that suddenly the vision will improve and everything, but that should be clearly conveyed to the patient that we only try to arrest the disease at that stage. So to conclude, we can control the burden of the glaucoma by raising the awareness about glaucoma, increasing the early detection, enhancing diagnosis and find out the cause of condition and treat them, and ensuring availability and affordability of glaucoma diagnostic and therapeutic. That way we can combat the glaucoma blindness. Thank you.
Thank you, Dr. Sumita, for nice talk. Our next speaker is Dr.
So, ma'am, there's also one more thing that we realize, that there can be misdiagnosis, because especially in the glaucomas that are not asymptomatic and those who have headaches, usually the patients never come to an ophthalmologist. They'll go to the medicine person or the neurologist, and they don't have a SOP or protocol that every headache should ideally be seen by an ophthalmologist. That is what we are trying to propose in the park, because every headache is not referred to an ophthalmologist, especially by the DM. The people who have already done DM, they will say that, find it below the dignity to refer to an MS or MD person. And then we realize that those patients have been just treated with painkillers. Yeah, but now more and more So we did a small study for headache patients, and we found that most of the headache patients were referred to medicine and neurology. So that's the reason. Also, ma'am, there's one more thing that we need to stress on, why they are missed by the ophthalmologist, because they should see them at different times of the day also. That's why the diurnal variation. So that also needs to be. Thank you.
Good morning, everyone. I want to thank AIOS for giving me this opportunity here. At the outset, let me just give you a quick brief about why this was done. Of course, each one of us knows how diabetes has come up as a big epidemic, and we are all now trying to get into and educate our patients about the lifestyle changes that they can do. What I understand here, living here for last n number of years, one always believed that people were walking long distances, had very healthy diet in the hills, and things would be much better compared to any other place. But when we do any kind of screening camps of detecting blood sugar levels, just blood sugar levels, you find that diabetes is frequent and common even in the hills, where people are walking and where the lifestyle issues are not there. So there is something happening to us, our diet, the way we are living our lives. When we were planning for a development of some education material for our diabetic patients, we find that we have a various subset of population in our hills. Number one, the people may be literate, people may be totally illiterate, or people could be just semi-literate. So needed to know, what do they know, how much, what do they do if they know. So this was an extensive study, and we had taken almost I won't go through this, but we included all. We included all the patients, but there were very few patients who were between the age of 10 and 20. And we excluded all the patients whom we could not examine or who refused examination. So here, what we did was, this was all known diabetics, established diabetics. There were almost 1,600 patients. This study was done not here, it was done in the Tiri District Hospital, Tiri CHC and in Tiri PHC. So it was not done in the city at all. It was done only for patients who were there. And there we have identified patients who were living in the city itself, Tiri city itself as the city, though it's not a city. So our population subset was 44% of males and 54% male and 46 female. The age group was on the higher side, 59. So that's why this number is there, that we had 73% rural there. Occupation wise, if you read this word skilled, this was either they were running computer labs of some sort, or they were doing some kind of teaching, or they were involved in tourist thing with a small degree. That is where the skilled came, did not follow the exact skilled as you and I may think. Now among these people that we examined, the prevalence was there in both the subset. Almost the percentage was around 21 point something when we calculate it. And in this, most of the patients, they did have mild diabetic retinopathy. Duration had a correlation. There were 2% patients with proliferative diabetic retinopathy. I'll tell you the numbers later. Some of the numbers are not very nice. Okay, now what did we do? We just asked, are you aware of any ocular involvement in diabetes? Simple. आँख को कुछ होता है क्या? That was what. And what you find is that a large number of people are not aware. Women particularly were not aware. Then, if they were aware, are you aware of diabetic retinopathy? Even in that, only less than 40% were aware. And these were patients who were already taking treatment for diabetes. These were not undiagnosed cases. See, I agree that, again, like glaucoma, diabetes is a sight stealer. Patients don't have pain. Patient feels मेरी sugar बिल्कुल ठीक चल रही है, मुझे क्या परेशानी है. So that kind of an attitude is there definitely. When you compare this in comparison to the education status, you find even when people are educated, even when they have access to healthcare, almost 40% are still not aware of ocular involvement or diabetic retinopathy. Now, see, duration again is so important. When somebody has had diabetes for more than 15 years, even then, almost 35%, 36% are not aware that something can go wrong with their eyes. So when you look at that, you decide and you think and you divide, go back and ask more questions. This is what I did. I asked for source of information. Because if you are going to your healthcare provider and he is telling you something, you would probably understand. Now, when I write doctor, this includes all, including the RMPs. But in this RMP, most of the patients who were aware, most of the information came from these people who were diabetologists or were practicing diabetes specifically. Lot of times, the regular physicians are not educating patients about the systemic involvement of diabetes. Then people who knew about diabetes, you can go back and ask some more questions. So, would controlled diabetic have some problem? Again, they don't know. So, almost people who were skilled, even then 24% did not know. In comparison, if you just ask them, is it curable? I mean, they don't know. People who know, even they don't know whether it is curable or not. I forgot to say, we had done this kind of a study for Pauri Gadwal almost before COVID. At that time, this was not there. This time, you find that so many people are getting information from YouTube And so many people who had some information were actually getting it from what? The WhatsApp University. When you talk about the duration of diabetes, and if they were aware whether diabetics again would have eye problems, or whether they would be prevented, or whether they could be cured. Even with duration, you find that almost 40% did not know anything about it. So this is actually set and subset. I'm sorry about that. When you ask people who are aware, these are the people who were actually aware, would they still go for ocular examination? 42% patients who were aware that something can go wrong actually went. 47%, they didn't know. They were aware, but should you go regularly? They did not know about it. Patients who were undergoing regular examination, most of the patients were coming from the Tiri city itself. From the villages, people were not coming. Again, in that, women were much less compared to the others. I would just summarize here and say something. What we realized was that there was an equal incidence of diabetes and diabetic retinopathy even in the hills, despite their lifestyle. That was one. The second thing was, what we realized was that the patients were not being educated about diabetes associated systemic involvement, even by primary treating consultant. Lot of patients were getting treatment at the government facility. Few were actually using, I did not put that slide because of whatever reasons, but a lot of patients were getting treatment from the government facility, and I can understand physicians are overloaded and they do not have time to educate when you are at CHC or a PHC or a district hospital level. Lot of patients who actually were getting some information were getting them from their opticians. So that was almost 12% patients were getting it from their opticians. So based on this, actually we devised two education leaflets, one for the semi-literates and one for the literates, and one 2-pager to be given on WhatsApp for patients who are coming to our OPD. Ask their number and give them this, because if you are too busy, just share that. If they are reading WhatsApp, they might as well read it from the right person. So this is something that I wanted people who are here to do, was just have one liner, one page, 4 lines, share it with your patient. Ask your resident to share it with the patient. At least they would know what to do and how to do things better. Thank you so much.
This is really very interesting, especially the use of WhatsApp for education. Also, it's very surprising the way even those who have been diabetics for 15 years, as you said, don't know about it, because they have been going to their doctors, they have been taking their treatment, and still they don't know about it. So that is a really eye-opener. Thank you, ma'am.
Actually, some of the things where I was seeing these patients as a VR surgeon, a patient has diabetes for 15 years. आँख क्यों नहीं दिखाया? पता ही नहीं था. So that was something very heartbreaking to us. Thank you.
But I think we as an ophthalmologist, we are also we are also responsible, because common practice, we are not seeing each and every patient fundus examination. So thank you, Dr. Renu, for nice presentation. And our next speaker is Dr. Ashwini Kumar, and topic is Hope in Hopeless Conditions, Visual Rehabilitation.
Surgeon of Mahavir Netralaya, Patna, but a brain hemorrhage made me hemiplegic. So I had no option but to start a new treatment. So I went to Shankar Netralaya, went to LV Prasad, went to BBI Foundation, and started a new treatment of visual rehabilitation in Bihar. And lots of people helped me in survival. So I want to repay them. I can't repay them, but I need your blessings for my future. So I start low. I can't. So introduction, low vision is the term used to describe significant visual impairment that can't be corrected with glasses, contact lenses, medication, or eye surgery. So it includes loss of best visual corrective, best visual acuity, BCVA worse than 20/70 in the better eye, significant visual field loss, tunnel vision, as we all know, and then the legal blindness. I won't go into detail. Next कैसे करते हैं? See. So spatial interventions. We used newer instruments like monocular and binocular telescope for the distance vision, for near vision handheld magnifiers, illuminated, non-illuminated, pocket magnifiers, dome magnifiers, half-eyes, cutaways, and for treatment, different kind of magnifiers were given for visual correction and improvement. There was a very unique M training. Means I told patient कि आप बड़ा M बनाइए गर्दन घुमा के, so that they can see the periphery. So we gave lots of magnifiers. Next कैसे करेंगे? So we found there were three patients were of retinitis pigmentosa. One was coloboma, 4 had nystagmus so and so, and 6 had Stargardt's also. And that this way you can see what we increased. From vision PL/PR to 660 in 8 patients. They could read newspapers. Counting fingers 6 by 16 6 patients. Counting fingers to 6 by 36 in 3 patients. Counting fingers to 6 by 18 in 3 patients again. 6 to 613 in 9 patients. No improvement was in 4 cases. We examined total 36 cases. So conclusion is the proper diagnosis, treatment and rehabilitation helps in improving the vision as well quality of life. The management of low vision needs both visual correction and rehabilitation, which may take several months of practice at home and daily life. Discussion. Low vision correction is a worthwhile investment of time and resources. Thank you so much.
So thank you for this because sir, it takes a lot of patience to sit with a person and understand their whole lifestyle and create the aids around those. So that is a very patient and needs a lot of patience. Yes.
Thank you, Dr. Ashwini, for nice presentation. Our next. Peak Decruise, and her topic is Mindset Mystery, Delivering Bad News, Staying Calm Through Surgical Complication.
So, very good morning, everyone. So, I'll be talking on a mindset mastery for delivering bad news and staying calm through complication. This topic may be not very relevant to senior surgeons over here, but I think still I have seen some senior surgeons at my hospital itself who was a retired officer from district hospital. But the way she was delivering bad news, from that I understood that there is something to learn, because she drops it like a bomb, blaming everything on the patient's eye. And then when the next post-op visits itself, she'll start ignoring that patient and she'll start putting that patient for the junior doctors. So there is something to learn in how to deal with these patients. Maybe in government sector, we will not get so many allegations or problems with the law and suit, but in private practice, it's always there. So it's always best to learn how to deliver this bad news and how to deal with these complications. So practicing ophthalmology is always exhilarating and fulfilling when you're able to help the patients recover their vision. But there will be times in everyone's life when we need to tell the patient that there is some negative information about their prognosis or something that has happened during their surgery. So are we really prepared to be the bearer of this bad news? Common complications that we face is PC rent, endophthalmitis, nucleus drop, no visual improvement. Then you found in the post-op that you have missed a retinal pathology. So the best thing is the need for a good preoperative chair time. Good preoperative counseling can save a lot of issues. We can detail about all the possible complications, giving example, 10 in 100, this can happen. 2%, this can happen. But the best thing is, after counseling, reassure them by just explaining that this is just a common set of complications that we say to everybody as a common protocol. It may not happen to you, but as your doctor, I will guarantee that I can give you the utmost care so that they will be also at little ease. So once the complication has happened, how to break the bad news? First, you need to prepare yourself. For that, you need to know the patient's background, their support system, that who is going to really take care of them, their financial system, their educational background, their level of understanding. And when you're delivering the bad news, be confident. Maintain eye contact, no nervous gestures, no stammering, even if you are guilty. Be assertive while talking. So there are certain protocols that are being set forward by the doctors itself. This one is called the SPIKES protocol, which was developed by the doctors in the oncological field. So SPIKE stands for Setting, Perception, Invitation, Knowledge, Emotion, and Strategy. Setting means you consider a comfortable time and a private warm space to set the meeting with the patient along with the bystanders. It is necessary not to rush the news like dropping a bomb. Take a moment first to connect with the patient and the bystanders. Whether we understand it or not, this may be complications may be common for us, but this, what we are going to say, is going to change that patient's life. Second is perception. Perception refers to the patient's current level of knowledge. You start from there. Assess whether the patient already knows or suspects that he had a complication from the conversations that had already happened in your operation theatre. Invitation. Invitation is asking if the patient actually wants to hear the detail about that complication. If he doesn't, don't stress. If he wants, then also explain very lightly, don't over-explain. Knowledge. You need to share the news clearly and compassionately. You should not be vague. You should not blame everything on the patient side. Some people say, आपका आंख इतना खराब था, मैं बहुत मुश्किल से ऑपरेशन किया है, फिर भी कुछ नहीं हुआ. Don't tell like that. Try to say in a way that's not all their fault. You can do something for them later also. So it's important to be clear and direct and remain considerate and empathetic. Avoid using vague language as it can create confusions. Try to acknowledge the emotions of the patient. Create a space for the patient to react. They might react. They will express their emotions. Put yourself in their shoes by identifying their reaction. It can be sadness, angry, shock, denial, and help them also in identifying what they are doing. Later, put a strategy. Discuss the next steps and care plans. After delivering the bad news, offer the support that you can help give them to ease their tension. This will show that you care and is willing to help. You should come up with a proper follow-up plan, outline a clear plan on how to follow up and what are the additional financial needs that will be needed, what are the additional surgeries that is going to be there, and what all you can provide and what all you can help. Similarly, there is another protocol called the BRAKES protocol. This is being used in the UK, almost similar. Just three things differ. Exploring means exploring from what the patient already know about the complications. Announcing means announcing with the emotions. And kindling means finally understanding how much the patient has finally understood from what you have explained. Now to the second part, how to stay calm when you go through a complication. This is particularly relevant to younger surgeons. Complications are inevitable. Everybody has complications. We evolve and learn through our mistakes and complications. So, once a complication has happened, accept the complication. Stop denying. Even I also had this thing. There is a PC rent. I feel like, yeah, I think there is a PC rent. But my mind start denial saying, nahi, dal do lens. But stop that denial. Make sure, put tricoat, stain and see what is really happening. Stop denying, accept the complication. Be mindful of this situation. Stay calm, take 1 or 2 deep breaths and say this to yourself. Yes, I made a complication. Everyone does. It happens even in the hands of big surgeons also. But I am going to handle it in the best possible way I can. Concentrate, compose, stop being anxious. There is nothing you can do by being anxious. Give yourself a minute or two. Think of a recovery plan so that you can minimize further mistakes and further iatrogenic complications. And never abandon these patients. Be empathetic to them. Do the rightful things to get maximum benefit to that patient. Be considerate in all of their follow-ups. Get help from your colleagues. If it is an IOL drop or a nucleus drop, get help from your VIA colleagues and do the best for that patient. So to stay calm, finally, you have to practice certain self-regulation techniques, which include breathing techniques, practicing mindfulness, practicing grounding exercise, and control your emotions. So mindfulness is a very simple technique where you just give a 5 minutes or 10 minutes before your surgeries. You just sit in a calm, comfortable space, take deep breaths and exhale through your mouth 5 to 10 times before you go to your surgery, especially for the junior surgeons. Do this before you start your surgeries in your earlier part of your career. This helps to ease the tension and actually avoids a lot of inadvertent tension-related complications. So finally, there is something called as a spider web of complications which happens with the younger surgeons. One complication, again another complication in the same OT, or it keep on happening in the upcoming OTs. So for this, you have to compose yourself, you have to move on, understand that this complication has happened, stop thinking about what has gone wrong. Remember, you can't change anything by blaming yourself or feeling guilty. So you need to refocus, give your 100% concentration on your next case, get your mind back in the game, complete that OT list. After the OT, you try to find out what went wrong, discuss with supporting colleagues or with your seniors what you did wrong, what you could have done better. Thank you.
Thank you, Dr. Rakhi, for very interesting topic. So every good surgeon is having bad news. So our next presenter is very interesting, Dr. Prasanna Venkatesh Ramesh, and topic is virtual reality ophthalmic ocular metaverse, the novel 4D cost-effective holographic ophthalmic AI metaverse with augmented reality.
Thank you, AOS, for this wonderful opportunity. So I'm going to take you into a module of teaching, counseling and surgical simulations that I have made at my center in Trichy, Tamil Nadu. So we all would have seen movies like these, Iron Man with holograms, and a lot of science fiction, right? So these were some of my inspiration which led me to make something similar in ophthalmology for the purpose of teaching, counseling as well as for diagnostics. So this is my patent protected innovation, and these are the 6 modules that I'll be covering each in a minute. So for me, ophthalmology was an imaging based field that we all know. To understand the subject, can we really make images moving in terms of animations? You can see a iris process on your left, and then you can see a peripheral anterior synechia on the right. So I show animations like this where an iris process is more of fine strands, whereas in PAS you can see more of broad basal tissue of iris, right? And then when you take them into a real-time scenario where how an iris process is more fine and arborized, which doesn't cause any occlusion to the angles nor cause rise in IOP. Whereas on the right hand side, the PAS is more broad-based, it adheres with the angle and also causes rise in IOP. So this is what I really started understanding in conveying the concepts better. Can we convey it through videos? Again, this is one of my animations of a pupillary block. You can see it's only a 10-second animation. So if we are going to teach, why do we do YAG PA, right? For a neophyte, we tell them that the cause happens here and the effect happens here. So because the posterior iris is in contact with the anterior lens or the pupillary block that we call here, the aqueous is not able to come through this, which has to go through this, and that is why it pushes and the effect happens here. So that's why we do a PA here to bypass the system. So these are simple animations that I started making to convey complex concepts simple. So again, this is another 1-minute video of whole glaucoma in a minute. Can we really show it to an undergraduate or a first year postgraduate? You can see again, this is one of my fundus pictures. For the first 10 seconds, I am showing what is the increased vertical cup disc ratio. Then we are slightly zooming in the video and showing how the notch is present and the bionetting sign, slowly taking them into higher concepts like basic sciences. ISNT rule is breached because of the notch. There is inferior thinning of the neuroretinal rim. Coming out and then showing the RNFL defect, pulling this picture down, taking the patient's own visual field, showing the superior arcuate scotoma, reducing the transparency of the fundus photo and keeping the OCT on top and showing the ganglion cell layer as well as the RNFL damage. So you saw how many points we are able to convey when we teach concepts in a video based manner, right? And I also publish my work, so you can find these publications in IJO as well as other journals. Again, complex scenarios like ALT versus SLT. See the spot size difference between ALT and SLT and where it is given. Always make sure you orient it anatomically. So I first show the anatomy and then show it is between the pigment and non-pigmented trabecular meshwork that we place the spot. Another dying concept of argon laser peripheral iridoplasty. So these are all concepts that we learn a lot of theory, showing a normal angle and then showing what is an oppositional angle and then showing how a simple laser can actually open up an oppositional angle called argon laser peripheral iridoplasty from a cross section angle. Can we show this from a front on view? Yes. Again, this is another animation. All the animations here shown are made by me. You can see again 24 spots are placed in 360 degrees. Can we show another angle of ALPI? Yes, we can show the gonioscopy as well. See how the spot is given and how the iris actually retracts the oppositional angle from the closed chambers. Again, these are all videos of mine in my YouTube channel, which goes in my name only. You can, for the love of teaching, we have made many videos. Again, a simple cataract surgery. See how the root of iris or the iris falls back, how the ciliary body falls back post cataract surgery, how the scleral spur also slightly falls back, and even how a peripheral anterior synechiae can actually break when you do a simple phacoemulsification. So then we started creating a lot of unanimated models into 3D. So first it started with animation, then it went into 3D model making, where circle of Willis, cavernous sinus and the eyeball was created. And once these 3D models were created, you can see I gave it in a smartphone where you can click by the button and you can go and access angle, or if you want to go and see the fundus, you can choose whether you want to enter a anterior segment or a posterior segment. So this was the second innovation called the unanimations, where again confocal images were used for autofluorescence, infrared. You can see the collections: fibrovascular band, retinitis pigmentosa, RNFL defect, myelinated nerve fibers. So moving from unanimations to animations, this was the next level of evolving, and you can find this publication as well. Then came in the real 3D innovation, where the holograms was created in the smartphone. On the left hand side you can see that it seems as if he's moving through thin air, but on the right hand side is the view that you can see in the camera, that we are accelerating the learning for MLOPs or undergraduates or even for first year postgraduates. You can see the exact retina for what a retina surgeon will see in real time on day one of the curriculum, when you are trying to teach complex concepts, even undetectable structures like a circle of Willis, cavernous sinus, which we never really have seen it in 3 dimensions, right? So we sat with the anatomy of Cunningham's, Chaurasia, did all the 3D recreation, and again for YAC-PA counseling, showing the angle. Again, this is an NTG patient where a color fundus, and this is an RNFL defect, everything in 3D. So this is also published and validated. And then came the holographic 4D, where you can actually touch this with the headset that we innovated. You can actually move it. On the right hand side, it will look as if he's moving through thin air, but he's actually moving through the structures, and a whole museum of this has been created at our center. I have not brought it here for logistical issues, but this is the future where even examination can be done in EMR, in 4D, and even the OCT filters that you can actually see. It's a very promising time, my dear friends. Ophthalmology is an imaging field, and we have also created the whole neuro-ophthalmic imaging itself, which we always tend to mug up, right? But can we have something to really have this kind of a aura or a museum armamentarium, which helps us in getting the complete concepts of innovative learning? And this is my daughter's picture. Again, the Gen Z kids, as we were all talking about, give or take, they are into technology. So technology is here to stay after COVID, and these kind of technologies are being there. I think we need to make sure we use it for the right purpose, so that we tend to pass on the much better tools forward. I'm just summarizing it. So this is the flow chart. If a patient, again for diagnostic purpose, enters into our hospital, you can see again we are also adding the OCT filters into the fundus as well. So this is something that is evolving and very much into the armamentarium. And to summarize again, I'm just showing this one particular slide, the simulations that we have made before I close it. So this has a role in surgical simulations as well. You can see again any surgery. Currently we have cracked the code for MIGS, minimally invasive glaucoma surgery, because that cannot be done on a human eye or even for a cadaveric eye, because the angles really don't be there. So this is one of the models that we created to practice at your place. You can sit, put these headsets, and you can actually practice these kind of innovative mixed surgeries. And then last is the puzzles that we made. I think ophthalmology is a very beautiful field. It's an imaging field, and we are trying to create the 6 dimensions, or it may be even more, called the ophthalmic metaverse. Once again, thanks AOS for this opportunity to share this on teaching, counseling, diagnostics and simulations. Thank you.
Thank you, Dr. Prasanna. for very nice presentation, and AI is future, and I think it will greatly help to all ophthalmologists. And your videos are freely available on YouTube?
Yes, sir. My channel is open access, sir.
Okay.
And my
okay.
applications
Thank
are also free only, sir. It's not
you.
cost.
It will help greatly in
sir.
counseling.
Yes, sir. Thank you, sir. Thank you.
And our Veen Vasist is effective refractive error coverage and effective cataract surgical coverage in India. Result from National Blindness Survey and other studies. I think he is not here. So, any questions?
I think we had a very fruitful discussion, even though in the morning we felt that this would go to an empty hall. But thanks to all of you, and this a beautiful way to end the session. And I think if no one has any questions, we can wrap up the session. And we can please call all the speakers for a photograph once Sir's question is done.